Yeah. So I said, you know, I thought it was a little one. Oil. Right. You can take the sensation off. Look at the time. And you can take like
Grateful, sleep. There.
Well, that, yes. Good morning, everyone. We're going to get started. I did think that so maybe I'll be here a few minutes. Oh, right on cue. I just thought about you.
You're always talking about it.
Good morning. I literally just said that I expected you to be walking in. So here we are. So good morning, everyone. We have all of our board members present. It's exciting. Obviously online. Which is great. So we will call the meeting to order. Sounds like it might be summer this week, so happy summer, it's coming. And good morning to everyone. Glad you're all here. I will ask for a motion for the March 4th. It's been a long time ago. March 4th minutes. Thank you. Second. Any discussion? All in favor, say aye. Thank you.
Hi.
Thank you. All right, so we will jump into the health administrative report. So good morning, everyone. As you know, I use this time to share with you updates about staff, about contracts. Update. We actually have a few new people in the room this morning. Thank you, Teresa, for reminding me to project and performing. We have a few new people in the room this morning. Ashley McGarity, Tyler Addison, and Lauren Brooks. Ashley has joined us as the new solicitor for Health and Human Services. So while she is not part of the Office of Public Health or part of Health and Human Services, she's part of the solicitor's office. She will be the designated solicitor for us and will be joining us for our meetings going forward. Ashley, would you like to say a little bit about you or? Sure. First of all, I'm very happy to be here. It's my first board meeting in general. So, just background about me, I come from immigration, so very wild field. What I like to explain about immigration, I love to speak that really cool. So I was glad to have you. Tyler Adamson joined us in March, actually right after our last meeting as our new director of health equity and epidemiology. Tyler joined us from the Maryland Department of Health, where he served as director for epidemiology and evaluation. He has a lot of great background experience in equity in cancer, in cancer surveillance, and surveillance. We're very excited about him. Would you like to?
Yeah, similarly, Tyler, I started in community health background, and vaccine research. Decided I didn't want to do that research ever again. So sort of process the bachelor's point, I realized I need to do some more skills. Started back to school for my epidemiology. I worked in Capitol Hill. I worked in the American legislature. Needed a break from that, and about leveraging health inequities.
And Lauren Bruce. Lauren recently joined us after his class. As our new quality manager. Lauren actually joins us with extensive experience in shepherding accreditation processes for both Rhode Island's Department of Health and the Philadelphia Department of Public Health. We're very excited that she will be joining us. She has exactly what we are looking for to shepherd us through this accreditation process. She will be picking this process up with us and carrying us through the accreditation process.
I did my master's public health stressful, and I love my time at the City Health Department. And also learn a lot. I am part of health, so it's something I've done before, and I believe the value. I think that people are
And before you go, I just want to make sure that for anybody who's on the live stream, there is a copy of the agenda posted on the website and the other meeting materials, including the agenda of the program summary. In terms of funding, we continue to submit our renewal applications for funding that we already have. So in March, we submitted our renewal application for the Overdose Action Project, which is funded by we received communication that we could anticipate level funding for that initiative. We submitted our renewal application that we should receive notice of award for that by August. That project runs on a September 1 to August 31st timeline. So August 31st would be our date here. In addition, we are about to submit renewal applications for our community safety program as funded through PESAP, and is also through our public health emergency preparedness program, again, anticipating level funding for this area. In terms of contracts, the Board of Commissioners in March, again, right after our last meeting, approved a new software platform for our environmental health and water quality management teams. We are anticipating that contract will be signed and returned, and that we will be diving in very quickly to get that software implemented by December. In addition, the Board of Commissioners approved about a dozen public health communication vendors for the Office of Public Health to utilize for a variety of public health communications. So we didn't, at this time, these aren't contracts for specific projects. This is an approved list of vendors that we will be able to access and leverage over the next 18 months or beyond for very specific public health projects, health communications campaigns, informational materials, technical reports, issue briefs, things that helps us to expand our capacity beyond what we have here through our comms team and through our subject matter experts. Helps us to fine tune and support health data. Those are my updates for this meeting. So we take it over. Are there any questions? Your agenda indicates that Christy Goodwin is going to be giving the Community Health Improvement Plan update. I'm actually going to give that this morning. Christy has been shepherding this process for us over the past several 2 years. Plus, the Community Health Assessment and going into the Community Health Improvement Plan. Next slide. I can give just a brief update today. We have engaged more than 50 organizations over the past few months to provide input on focus areas and goals under those top 3 priority areas that we identified. those top 3 priorities were identified by the survey respondents. And so when we asked, what are your your community health priorities, they pulled out math across other counties across the Commonwealth and nationally, chronic disease, mental health and wellness, and environmental health. So through those what we call think tank meetings, we were able to identify some focus areas within those buckets. It's a pretty big bucket. So when we talk about chronic disease, we're talking about hypertension, reducing uncontrolled hypertension, increasing physical activity, ensuring access to care when people need it. In terms of mental health and wellness, what we're talking about really is focusing on that prevention side, focusing on social connection and isolation and loneliness, particularly among older adults and other groups that are more likely to report mental loneliness or disconnection. And in terms of environmental health and safety, what we're talking about is access to safe mobility, getting to from point A to point B safely, having access to open space and breathing space, which we know that has incredible impact on stress, on mental health, and cardiovascular health. So those were the top 3 buckets that were identified by our residents, our respondents to the survey, and focus areas within those. As we look at the CHIP, though, there's a lot of intersection with other areas of health and human services work. And through Dr. McKernan's vision and support, we're actually going to grow this CHIP such that it's really a strategic framework or a guiding framework for many aspects of health and human services work. So we're going through a process now of crosswalking existing plans and priorities and goals for our colleagues across health and human services, and integrating those into a broader CHIP. We anticipate adding 2 additional priority areas: maternal and child health, as well as behavioral health and wellness. There will be additional information that we'll be sharing probably over the next week as we dive into those areas for teaching. Are there any questions? So we're going to move into Dr. Montgomery's report, and we're going to talk about Ebola risk, monitoring, and public health response.
Thank you. Whatever this is. Going to give a little bit of discussion. Basic outbreak that's going on. Phil will talk about response to that. Slide, please. So general overview about this current outbreak. Keep in mind that Ebola has been around for very long, since about 1967 or so. And we see outbreaks on average about every 2 years. So that in and of itself is not unusual. However, this is of concern particularly because it's even at this point the 3rd largest outbreak. It's still being depressed pretty significantly. There's over 1,000 confirmed and suspected cases currently, and quite likely more to identify the data is not increased at this point. The good news is that it's mostly confined to the Republic of Congo and a few cases in Uganda as well. This particular strain is the Montgomery strain, which is different than your strain. Mostly, if we can say, somewhat the good one, is the mortality rate significant. So the main strain of Ebola, typically mortality rates are extremely high, somewhere around the 80% range, which is pretty significant. The Montgomery strain tends to be somewhere around 30%. So as of right now, I believe the fatality count is just under 4%. There is no vaccine. There is a vaccine for the Zaire strain. There is not current for the Montgomery strain. It is being worked on, of course. The important thing for us is that we do consider the risk in the United States to be pretty low. There's pretty significant monitoring, which I will talk about that in terms of travelers to affected countries. It is right now just confined to those 2. As of this point, we've not identified any confirmed cases.
I'm going to review public health response, and I just like to remind people, like Rich said, this is not the first viral fever outbreak. So these recommendations we've been doing in response to with Marburg and so right now there's an issue of of a travel health notice and precautions for travelers outside of into this region. When travelers come back to the U.S., there's a limitation of entry restrictions for certain travelers that go to the country surrounding that 21 days travel and exposure to the country. Right now, all travelers are being routed to 4 specific airports for designated entry. When those individuals enter the U.S., we do enhance or CDC does enhance travel and arrival screening. So they are screened for risk, travel dates to assess what category of risk they're in. From there, this is a collaborative approach from CDC, Pennsylvania Department of Health, and our office. We are notified of any travelers that are residents of Montgomery County. Our process is to redo that screening for each resident, as well as obtain information about where they'll be in the next 40 days and emergency contact to be able to do that. We also do 21-day symptom monitoring. How we do that is through the text message system that we can on the IT to that system. Individuals respond in Microsoft Forms with they're required to report us at 1 o'clock every day. If they do not report us, to reach out to them. If we can't get a hold of them, we're also reaching out to their emergency contact. If they are symptomatic, we will work with them to be in Department of Health to coordinate to a healthcare setting that is appropriate.
Do you expect the number of entry airports to change, or is it sort of stay once they decide that's the number?
I really don't have the answer. It's really going by CDC. I know that we usually try to make the limited the airports that people come in. I feel like this is a larger list compared to other responses. We usually see Dulles as one of the primary that people want to for other responses, but this I really don't know. Okay, I don't know.
I find it fascinating. And then for patients who are on the monitoring capacity visit by 1 p.m., do you find that they are typically compliant, or that you do have to take them?
No, they are very compliant. Okay, yeah. And that we set that up and get very clear about what it is. Very clear. You know, people have life, it may forget. So we're very clear about how you're responding, making sure that they're available to be called. Other questions?
One quick question, I guess, for Victoria, for you. The viral illness, I'm assuming is the respiratory problem, water transmission, and how long does the symptomology, or I guess, is the carrier for only 21 days? After that, are they considered not the carrier of the? What is the time period?
Yeah, I have to double check. Specific time period, but this. Curious as to where you're traveling from. In other words, if I'm visiting to Africa, I don't usually come right back to the United States. I travel to Europe and stay and then come back. So how does that all fit? Is Europe doing the same thing?
I actually have an answer to that. I do know when entry screening is happening, we can get a list of where they traveled in 21 days prior, what airports they were at. That is done by CDC screening. But again, I don't know really what you're doing. Yeah.
Yeah, I'm okay. Thank you, that was great. And now we'll move into the 2026 summer emergency response preparation with Megan Young.
Summer is upon us. We did have some 90-degree days. Nice welcome instance, but the heat of the summer is upon us in more ways than one. So FIFA World Cup is kicking off next week. I think we've been talking about this for what feels like a very long time, and now it's finally here. So Sarita was nice enough to put this beautiful calendar together. Thank you. Laying out where all the activities in the city of Philadelphia are going to lie. So as you can see on the calendar, We are at today, June 3rd. So Philadelphia has started weekly surveillance reporting for diseases. So today is a reporting day. We have our disease report in already this morning. We will do one more week of weekly surveillance, and then we'll start on the 15th with daily surveillance through the end of the games. Pride is coming up this weekend in Philadelphia. Philadelphia is expecting a very large representation at that, so they have kind of put that on as an event to be aware of just in the response world. Our first match in the Philadelphia area will be on Friday, June 12th. That also kicks off Fan Fest, so that's what FF stands for. Philadelphia is so graciously hosting a Fan Fest in Lemon Hill, which will run the entire duration of the FIFA event. So this will go much into July. So 39 straight days in Lemon Hill. On top of that, we also have Juneteenth celebrations, which will be the Father's Day weekend. So you can see the days where we have designated matches. The week of the 22nd will be very busy, as I think we have like 4 matches that week. Next slide, Teresa. WA also stands for Welcome America, so that's another large event of note. The Welcome America concert on the Parkway down in Philadelphia. They're expecting, again, a large representation for that. So that is always an event that regionally we watch. That will wrap up on July 4th, which is also, coincidentally, Philadelphia's last World Cup game at 5 p.m. So that will be a very busy day on top of the municipal events that will be happening for July 4th and whatever else will be going on in the region that day. But as you can see, we will continue daily reporting, with the exception of Sundays. I should note that Philadelphia made the decision we're not going to do disease surveillance on Sundays. But we will do daily surveillance through July 10th. That gives us a period of time after the last game. But the activities are not over for us, unfortunately, because Major League Baseball rolls into town on July 12th. So we have FIFA Fan Fest going on. At the same time, we will have a Fan Fest for the Major League All-Star game. Major League Home Run Derby is on July 13th, with the All-Star game being held on July 14th. So again, still very, very busy in the response and surveillance world. We will go to twice a week surveillance starting the week of the 12th, and we will follow that through till the end of July. Now, Philadelphia has decided in the event that we are in a response posture, we have an outbreak going on, we have some sort of disease event going on, we will extend surveillance into August, but we will determine that as we get through the event. Final FIFA match is on Sunday, July 19th. Our neighbors in New Jersey will be hosting that at MetLife Stadium. So we have worked very closely, we as in the Southeastern PA region, have worked very closely with New Jersey. They've been on all our planning calls for the last year, as well as the state of Delaware, since they are hosting Ivory Coast. And I think, you know, it's a great surveillance network that we've built over the last year. Next slide, Teresa. So some things that we are kind of focusing on, you know, speaking for both ourselves and public safety, we've also done a lot of coordination and response planning with the Department of Public Safety over the last year, because we don't do these things alone, thankfully. So some things that the Office of Public Health will be watching and would lead in the event of a response, obviously an infectious disease investigation, any sort of outbreak scenario with a communicable or otherwise disease would be led by the Office of Public Health. Any foodborne illnesses, we know there will be a high potential for pop-up events linked to some of these fan fests and watch parties. So we're going to be super vigilant on any foodborne illness related reports that we get. Disease surveillance and reporting, I think I've covered that pretty well. And then because it's going to be June and July, it gets hot here. So we will also be watching our extreme heat. Division of Preparedness does the code red declarations within Montgomery County. So we are already doing our weekly weather reports, and we will be declaring code reds for high heat should we need to. So we'll be watching that. We are also reporting on heat-related emergency room visits as part of the disease surveillance. So regionally, that is being watched as In the event we get something not led by the Department of Office of Public Health, led by the Department of Public Safety, things they are specifically planning for, any hazardous materials response, so anything chemical, biological, nuclear, explosive, severe weather. We see a lot of that here in the Southeast region, and then any mass casualty incidents. They would be the lead on that. Office of Public Health would gladly support as requested. Next slide, Teresa. So some of the reporting that we are doing with Philadelphia and regionally, hospital volume. So we're very closely watching bed capacities at hospitals, especially our emergency room capacities. We have heard some anecdotal reports this week that several of our hospitals are at capacity. So we're watching that very closely because especially if we would get some sort of mass casualty or surge event, we could very quickly overwhelm our hospitals, and we don't want to do that. We have very close coordination with all the hospitals in the region, being led by the Healthcare Coalition. So I do think we have good visibility on where our hospitals are at. We are also notifying or reporting on notifiable diseases and clusters of concern. Obviously, any of our 74 reportable diseases in the county. And then emergency room encounters by type. This is just a smattering, it's not a complete list. Influenza-like illness, GI illness, COVID, respiratory, heat-related, and then overdoses. Philadelphia is watching the overdose numbers very closely. FanFest will have alcohol permits signed. So they're very interested to see if that leads to an uptick in ER visits. Next slide, Teresa. Some other things that regionally are being watched, obviously the Philadelphia Port Health Station, as folks come into the Philadelphia area through Philadelphia International Airport, they are reporting on the same cadence that we are. Poison control is also reporting, and it has been on all of our planning calls, which has been very nice this time. We have poison control early in the planning process. BioWatch is our federal air monitoring for bioterrorism agents. So there's a very vast network of bioterrorism surveillance going on, not only for World Cup, but also for FanFest and the MLB All-Star Game. And there's also surveillance monitoring in Delaware County for this event, since they are hosting Ivory Coast at Subaru Park. So very vast bioterrorism monitoring network. Philadelphia will be monitoring wastewater surveillance, as well as their medical field tent surveillance. So anyone who presents for care at a medical tent at FanFest, at Lincoln Financial Field, at Citizens Bank Park, that will all go into the surveillance reporting to see kind of what numbers are coming out of that response footprint. And then Philadelphia is also watching arbovirus surveillance for mosquitoes. Next slide, Teresa. So some planning and training, like I said, this has been going on a year plus. We've known that this event is coming for quite a period of time. So there's a lot of planning and a lot of training that has gone into getting us today. So we have built a public health response plan specific to 2026, summer 2026 events. It outlines our response triggers, our internal and external notification pathways. So how we're going to alert our department if something happens, and how we're going to share information with our partners should we need to. Our response protocols to different diseases, and then tools for management. Philadelphia has done a great job of producing some tools that we will be sharing out with our healthcare partners as far as surveillance, testing, and reporting. So that should come out this week. It was supposed to come out yesterday, but I don't think it's been released yet. We're going to take that. We are going to put some kind of precursor information to that for Montgomery County hospitals and how they should report. We don't obviously want them calling Philly. We want them calling us. And then we'll release that for our healthcare network. We also have been in regular coordination with the Department of Public Safety. We did a project over the last year to clarify roles and responsibilities for these emergency responses. Who does what, who's in the lead, what resources we're all bringing to the table. We also have regular meetings with them monthly. Outside of this, it just kind of became World Cup focused over the last year. And there is a plan developed for July 4th support. So July 4th is kind of the date that everybody is going to be very busy in the region. Obviously, we have a lot of July 4th events going on. We have a final game. We have Welcome America. It's going to be very busy. So the Department of Public Safety will be activated, and we will be supporting them as they've requested. Some training and exercise we've done this year, So in March, we completed a point of dispensing exercise. So our points of dispensing are our network for how we distribute medication, vaccines, commodities in the event of emergency. State asked us to test that this year in a functional manner, which meant open up the pod, run a couple people through it. We like to kind of go over and above. So we ran a full scale exercise. We ran 77 people through our pod. We tested it full capacity because we wanted to make sure we were good to go before World Cup event. We've also been part of the regional mass gathering workshop and tabletop. So this was a plan of how we were going to respond to a regional event. Should we get an emergency in our 5-county region, something like a complex coordinated attack, how we would manage patients, how we would communicate, things like that. Our Medical Reserve Corps, which is our cadre of volunteers, has done extensive training this year. They've done a lot of mass gathering, responder safety and health training. They were also trained with the Red Cross to support shelters. So in the event we need to set up a shelter, they can go in and shelter staff. So they've done a ton of training over the last year. And then finally, the county did a lot of mass fatality planning, and their tabletop exercise is actually right now. The Department of Public Safety with some of our preparedness staff are actually participating in a mass fatality exercise. Mass fatality is something we could see on a, I don't want to say normal basis, but it's a very real threat for us just because of our large transportation network in the county. So they are testing that, testing what would happen if we would get a fatality event that would exceed the capability of the coroner's office. So they're running that tabletop as we speak. I don't know if I have any. Oh, other things to watch. So I mentioned this a couple of times, just some other things that we are keeping a watch on over the summer. Obviously, Welcome America on the Parkway on July 4th. That will be a very large event. MLB All-Star Game, the 12th to the 14th of July. I think that will be a smaller event than World Cup. It's a shorter duration, but also baseball fans. So we're not going to see the international travelers that we would see with something like World Cup. And then within Montgomery County, like I said, July 4th, public safety will have their watch desk activated. We've been asked to virtually be available to support that should something happen, and we have staff prepared to come in. Should something happen, we're standing at the ready. And then our annual potassium iodine distribution will wrap up the summer on August 3rd. So we are running that as an exercise this year, very excited about it.
Yeah, go ahead. Do you go first?
Thank you for that presentation. I think the one question I kind of want to ask is in terms of surge planning, in terms of having either a mass casualty event or a mass outbreak, mentioned that there's a collaborative performance. What is the anticipation as the event goes close by? Is the answer to say EDs probably free up some, or hospitals free up some beds with the EDs? How does that planning happen in real time as the event gets close?
So I don't know if the EDs are gonna try to free up beds. We had a conversation yesterday with the healthcare coalition. Within Pennsylvania, there's several healthcare coalitions. Southeast has one that covers the Collier counties plus Philadelphia. There will be a healthcare coordination desk activated every day during this event that will be in real time watching the volumes. They will be implanted with the city of Philadelphia in the event that something happens and we need to do immediate surge planning. So we're kind of leaving the surge planning to the hospital, the healthcare coalition, because that's what they specialize in. But I know that a lot of the networks are looking at this, how they can move patients around within their network. The other challenge that several healthcare networks brought up yesterday in our meeting was in the surge event, getting staff in. So we're gonna have a lot of travel restrictions coming into the city. Now you have this mass casualty event, we're gonna have additional travel restrictions potentially coming into the city. How are we getting staff in? So that is something the coalition is working on this week with the city of Philadelphia, trying to figure out how we're gonna get folks into the city. Healthcare, a lot of healthcare facilities are also running a surge exercise on Thursday, where they're being asked to surge to 10% plus capacity. So how would they take these patients, how are they tracking them through their healthcare system? What are they, doing with them? So I'll be interested to see what comes out of that. The coalition is taking the lead on the hospital part of it.
I was gonna say the most recent example was Methodist having
Yeah.
flooded.
Yeah.
Moving 120 patients forward. And we sit at these conferences, talk about these patients, and some of them are very critical. So that logistical bandwidth to move, and like you said, I remember this example a few years back at the marathon, when they block roads off, even for the trauma centers to get in, is hard. So I think that planning is very good to have.
Yep.
Anticipate that there may be certain events where you need people who have access and public safety to know that who will then go inside.
So something that was communicated to the healthcare emergency managers yesterday that were on our monthly call, emphasizing the messaging to their staff that when they're coming into work, making sure they have their badges at the ready. So when they get to those checkpoints that may be enacted in the city, I'm healthcare. I need to come through. And then it sounds like the city's also gonna emphasize that with the police department and maybe working those checkpoints. You brought up Methodist, the evacuation that Philadelphia just had, I believe, last month. That also came up on our call because that is kind of our real world example lately of what happens when things go bad. So they also, I forgot to mention, within the healthcare coalition, there's the healthcare coordination team. And it's volunteers from various healthcare networks that are very well versed in healthcare emergency management coming together to respond to like the Methodist evacuation or a nursing home fire, working very closely with the county to manage those surge events or those evacuations. Normally, they would not activate until they're requested by a facility. However, for the summer event, the healthcare coordination team will be activated preemptively. So they will also be implanted with our regional readiness coordinator in Philadelphia's city EOC. They also may be implanted at some of the Philadelphia hospitals to help with that patient movement and coordination should we. And then of course, our suburban hospitals, and suburban partners, public health, public safety, we will be watching it through the reporting systems in real time as well, so that something happens. We're ready if we need to be.
Yeah, thank
So one of the things that we did across our hospitals are infectious disease physician leadership. So we have education for all the emergency departments and urgent care, looking for assessing people who are traveling internationally. What are their symptoms upon presentation, and immediately masking those patients and putting those patients into private rooms, not in the waiting room. Like, so we're based on the screening, and actually the staff, we're not requiring masking, but we are supporting it in a big way. And our staff still mask today. I'll walk around and people are still masked, which on my department, but particularly the registrars and the triage team, they'll probably be masked because the volume's high, and I already see it today. But yeah, we tried to be require masking, and then how far do you go into the organization with masking? We decided not to do that, but we went out with this whole plan around highly recommending. This is why, we talked about the international traveling and all that. So the EDs, at least my EDs, are overflowing every day, and we do have surge space, but that's used every day. So I wrote down the 10%. I'm going to see where we would put 10% more. On the roof.
And to your point, Barbara, the other thing that Philadelphia, I think, should be applauded for is over the last year, they have an infectious disease group that meets regularly, but particularly over the last year, Philadelphia Department of Public Health has really stressed to all of those healthcare partners the importance of really good travel screening, really good questioning of every patient entering that PD. What are your symptoms? Where have you been? Are you an international traveler? So that those potentially high risk patients are identified quickly, and we reduce the risk generally to the ED, hopefully. So I will commend Philadelphia for that, is they have really pushed that message of good travel history, good screening. And I do know that in some of their schools, they push that as well, making sure they got a really good screening. There was also a lot of talk over the last couple months of adding ICD-10 post in that would, flag like an international traveler or flag, World Cup related event. So that as we look back after all of this is over and we get a chance to rate, seeing how many ED encounters or hospital encounters were related.
Great, very good. Other questions?
We've never probably experienced anything like this in the last 10 years. This many people come one
Oh.
particular time.
Oh, yeah.
What was our last event?
2015.
So a little over 10 years.
But that was, yes,
Yeah.
that's where I'm, this is a sustained period. So I was thinking, I applaud everything that's done. It's amazing. But I'm thinking this is an opportunity afterwards to get all the people together and really say, okay, what can we learn from this? And it sounds like you're going to do that
Yep.
and then present that back to us.
Yeah.
Like, okay, because there's obviously huge opportunities.
There will be lessons learned from this 100%. So we will write probably in August. Once we know we're out of the monitoring period, we will write an internal after action report. We'll send a survey out. We'll do all
I'm
that.
actually thinking about a shared document
Yep.
from all of the.
There will be,
operating partners. That's all. Yeah.
yep, there'll be a regional one as well. Probably led by the city of Philadelphia, because that's what happened with Pope.
Hopefully in New Jersey and
Yep.
Delaware. Okay.
Yeah, they'll all be, anybody in that surveillance group would be part of that after action report. So Philadelphia usually leads that as the lead jurisdiction. But we'll have that, we'll do an internal one, just because sometimes we can be a little bit more specific with our recommendations. But we will gladly share that all.
I hope it's a very boring report.
I hope
That we don't have a lot to talk about.
And I will say, to Mike's point, the last time we did an event this big was the people visit in 2015, but it was a very short duration event. I think we were only activated for like 6 days. So the challenge, the planning for this was a little bit challenging because in some rounds there was a feeling that we went a little overboard for the Pope. Because we just did not see the attendance numbers that were originally projected. So it was that balance of how do you adequately plan without going overboard, but you don't want to go underboard either. And by the way, you have a 39-day stand back. So
Yeah.
Very complicated.
Thanks, Dr. Mustogi. Avi.
Yes, hi, can you guys hear me?
And
First, I'm sorry I'm not there in person, just driving to a hospital association meeting. But I want to comment on the report. It was a very comprehensive report. Actually covered most of the points that I wanted to make, given that, we're at the table with the planning with the city of Philadelphia. So it seems like you already have all of the information. So just more of an offer out if there's anything that you need in terms of what the hospitals are planning in the city. And I know, Barbara, you're at the table, and I think I heard Mike Lane there too. So I'm sure Redeemer's at the table as well. But if there's anything that I can bring back to you, happy to do that.
thank you, Avi. That's great. Thank you. And, I really want to commend, Megan and Michelle and several of our staff who've been, Teresa, who've been at the table over the past several months, not just preparing and organizing within Montgomery County, the health services and public safety, but also across the region, routine meetings across the region. Although, Megan mentioned, Philadelphia specifically, this effort really is a one, covering all of southeastern Pennsylvania, New Jersey, and Delaware. And they've also been actively putting on coordination calls, participating in coordination calls with other host cities throughout the United States to prepare for this event. So this has been a lot of work leading into the next month and a half. And I really cannot thank staff enough for all of this. Good work, thank you. So now we move into that questions. I think that is anything mindful of we're running back minutes behind, so I do that.
So we have a situation now where there has been a significant increase in medical attention for vector-borne illnesses, and particularly tick-related, especially this period. If Teresa, you can click on it. Yeah. We're a little under than we're a little concerned about this time. Next slide, please. So the important points to note is that tick-borne illnesses are really increasing significantly. It's both in this area and really across the entire country. But Pennsylvania in particular is one of the highest burden states. And that's this for multiple diseases, not just the chronic discussed. The reasons for this probably somewhat relate to climate change. It's longer seasons. There's a lot of obviously seasonality with tick-borne illnesses. But a reminder to everyone that they actually just spring, summer, fall. Anytime that the temperature isn't below freezing, the vectors can remain active. Ticks are still active. We can see these diseases. So particularly also as people spend more time outdoors, and particularly in grassy areas, and we have lovely trails that we always promote, we're going to see more human exposure. Next slide, please.
I don't think that you factor in pets as well, because the pets obviously attract.
So there is a risk to pets as well. To get a secondary transfer to humans, very unlikely, but it's possible. It's possible. But when I talk about precautions to take for tick checks and things like that, my focus is on people. But the same thing pretty much can apply for any outdoor animals as well. We should always be performing tick checks on dogs, cats, other pets that might be spending time. So we use emergency department visits for tick bites as kind of our marker for how active things are. You can see certainly there's some seasonality there. This is over the past 6 years or so. And there's a large increase in the spring and summer and a little bit in the fall as well, but then it never actually goes to zero. We will see an upward trend that has been going on really for the last 8 years. And not surprisingly, that when we look at these ER visits, the largest proportion of them are kids. Now, if you look particularly at that green line that ends, could be right at the end, that's 2026. Now, up until the beginning of May, we were seeing essentially record numbers. And we were very, very concerned that if this continued, we would see numbers that we have never seen before. However, it did taper off during May. My personal theory, and I do not have objective evidence for this, I think it's weather related. I think as now we've gotten back into warmer weather, we're going to see that intended uptick. Next, please. I really do. When we get down to Pennsylvania, so that was across the country. These are the Pennsylvania numbers for the last 8 years or so. And the solid line is the average. The bar graph is what we've seen this year, and it mirrors what I was talking about. We were seeing this very, very large surge in early spring. So Pennsylvania is always among the highest volume of tick-related visits, and we had an earlier onset this year than we wanted to do. We're seeing the largest increase, particularly in rural counties. So why are people specifically going to the emergency department for a tick bite? In and of itself, it's not necessarily within the category of emergency. But there's a lot of reasons, and a lot of it is concern and fear. So number one, there's a lack of information. People don't know what to do with this. So I hope that this presentation can be widely shared so we can share some of that information and people know what to do. Recognize that how long the tick has been attached is probably key. A short attachment, very, very unlikely to transmit disease. Longer attachments, you have to be much more concerned. And when people don't really know, they're going to just kind of default to what they know, and that would be go to emergency department. Speaking as a former primary care physician, I did know the bullet point, there's no reason why you have access to primary care, urgent care, if you don't
utilize those facilities, they are more than capable of taking care of it. A very, very important point, we'll go over this in a little more detail later, is removal of the tick. So there have been multiple methods promulgated throughout the years, very interesting things such as patch, out, to use petroleum jelly to smother it. All of these methods are not appropriate. We discussed it. I'll have a particular slide on tick removal as well. So if you have difficulty, if you don't understand how to do it, if you have difficulty doing it, if you're anxious to do it, a clinician can certainly be helpful. Another thing that I'm going to focus in on is where are we using antibiotics? So I have long been a very, very strong proponent of antibiotic stewardship. And I've had multiple discussions over the years about appropriateness or inappropriateness of use of antibiotics. Tick bites. This is a situation where prompt antibiotic treatment where appropriate is really urgent and very, very important. And there's also, in the case of Lyme disease, prophylaxis that can be done. So this is something that is perfectly reasonable to seek medical care for. Occasionally, there are actually true emergent symptoms. Severe allergic reactions like anaphylaxis, there's occasional tick paralysis that kind of mimics things like Montgomery syndrome. These are things that can be viewed as true emergency, but people should be drawn to emergency. Excellent. So there's a whole lot of things that ticks carry, and they're actually different categories. And I'm going to be talking mostly about bacterial, parasitic, and allergic, because these are things that we can do something about. The viral ones, they're not terribly common or uncommon, but the treatment is purely supportive. There is no antibiotic treatment for it, so I won't be focusing quite so much on those. First category is those viral illnesses that are called arboviruses. And a couple examples of Blasson, Heartland, and Bourbon viruses. Bacterial infections are the ones that we didn't hear about, particularly Lyme disease, which is most likely most common one. Just as a side, it is Lyme disease, not Lyme disease, but Lyme. Anaplasmosis, and this is something people are not aware of, it's rapidly becoming the second most common bacterial pathogen with tick bites or lichiosis. Rocky Mountain spotted fever, there's a whole series of bacteria in a class called Rickettsia that produce these spotted rashes. And Rocky Mountain spotted fever is the most common of those. Tularemia, relapsing fever, again, there's a whole list of these bacterial infections. Babesiosis, we'll go over this one in particular, is actually a parasite that the tick transmits to the human, which can cause red blood cells to rupture. And there's a very interesting one that's allergic called alpha-gal syndrome. It's been around for a number of decades, but it's gotten a lot more in popular discussion. It's kind of interesting how it happens. And I'll be discussing that one as well. Next. So our first one is Lyme disease, which is the most common one. If you look down at the lower left-hand corner, you see the relative size of the deer tick, the black-legged, which is the one that carries the Lyme disease organism. As an aside, the other ticks, the larger ticks, the wood tick, dog tick, Asian horn tick, do not carry the organism for Lyme disease. On the left, you see the adult. On the right, you see the nymph stage. Very, very small ticks. Sometimes hard to find on the body. By the way, on all of these slides, the upper right-hand corner, you'll see a map of Pennsylvania, which indicates by color the amount of cases per 100,000 within each county. The ones that are in gray have a total of 5 cases or less. So it's not 0, but it's not enough to be statistically counted. Very, very important for Lyme disease. It must be attached for a minimum of 48 hours to be able to transmit the organism which causes Lyme disease. If it's only on for less than 24 hours, even if the tick is infected, it will not transmit. The classic bullseye rash, and I actually chose an illustration that's sort of halfway in between. This one is clearly recognized. as a bullseye rash. Some of them are just big red spots, very hard to tell, and some of them are even more targeted. For clinicians, the hallmark for this is that the rash very rapidly expands. Although everyone is familiar with this rash, and that's what we look for, and we say it's absolutely Lyme disease, it actually only occurs about 30 to 40%. So you cannot rely on the presence of rash to diagnose Lyme disease. You have to maintain a high level of suspicion. If we catch it early, it's easily treatable. If it's not caught early, we have long, prolonged courses of antibiotics, but it can cause some pretty severe debilitating diseases, including neurologic conditions, particularly confusion of brain function. Very, very important for Lyme disease. It has been demonstrated that it's high risk tick bite. A one-time dose of doxycycline, given as soon as it's recognized, is preventative in most cases. So this is one of the really important things for people to seek attention to. And that's if the tick has been attached for more than 36 hours. That's the specific criteria cutoff. The other criteria are automatically met. It has to be present in a significant number of ticks, and you have to be in an area of the country where there's a significant burden, both of which we meet. There was a vaccine previously available for Lyme disease between 1998 and 2002, and just coincidentally, I happened to be the investigator on that vaccine, which phase 3 clinical trials. It was withdrawn in 2002 for a variety of reasons, mostly due to commercial issues. There were a few side effects, people with a certain specific genetic predisposition, but it wasn't commercially viable manufactured. There is currently another vaccine in development, which we expect will actually be approved fairly soon. It has kind of a prolonged administration, so it's not a single dose, it's going to be multiple doses, but it will be available soon. Next, please. Anaplasmosis, also carried by the deer tick. Now, this has a shorter attachment cycle. 12 to 24 hours is all it needs to be on. This is a disease that if you have it, it's not a surprise. It is sudden onset. This is like pretty much getting the flu, having not had a flu vaccine. It will hit hard, it will hit fast. High fever, typically 104. Shaking chills, muscle headaches, no rash. This is something that, particularly if it's occurring in the spring, summer months, I would encourage everyone to seek medical attention before, especially as these are times when we won't see much flu. So it's more likely something like anaplasmosis. This again can be treated fairly quickly and easily with antibiotics. Lung inflammation, increased respiratory function is a common supply. Next. Again, the deer tick, responsible for some people with esiosis. Now, this is not a bacterial infection, this is actually parasitic. And if you have to think of a correlation, I think of it as somewhat close to malaria in terms of what it does and its presentation. So it will enter the bloodstream, it will attach to red blood cells and cause them to disintegrate, or a process called hemolysis. The typical symptoms are essentially those of excess blood cell destruction. So you'll see jaundice, fatigue, anemia. Sometimes if it's not too bad, there are actually no symptoms whatsoever, and it's kind of found just coincidentally. This gets treated not with antibiotics, but antimicrobial, antiparasitic agents. So it's a little bit different, and this is blood test really. Next, please. So ehrlichiosis, this is a much more rare condition, but we are seeing more of it. It comes from a vector called the Lone Star tick. You can see that white spot on the body there. It's characteristic of. And just for fun, I was able to find an image of the first Lone Star tick that was identified recently. But so that's where it all comes from. Now this one The symptoms for this actually take longer to appear. It's about 1 to 2 weeks after the bite. Fever, chills, muscle aches, definitely confusion is a very, very common. This is a very flat rash. It's not that spotted rash. You see that stuff. Well, and definitely much more common in kids. There we go again with antibiotics. Doxycycline right away treats this. So again, very, very important to seek medical care. Next, please. And I talked about Rocky Mountain spotted fever and other spotted rickettsial diseases. The dog tick or wood tick is the one that transmits this one, and it is probably the most common tick. Right now, the numbers are relatively small for this, but they are still significant. The bacteria only takes several colors for this to transmit. So it doesn't require the 12-hour, the 24-hour attachment. This is just a few hours. We will see a definite fever with this, very, very intense headaches. And there's this spotted rash in particular. It starts around the wrists and ankles, then progresses to the rest of the body. And if you don't pay attention to it, it gets worse. It gets worse quickly. So this again, rapid treatment, doxycycline again happens to be the one that does the best for this. Next one. Now, alpha-gal syndrome. So this is named for a specific sugar molecule called galactose 1,3 alpha galactose. And this particular sugar molecule, but this is another one that's spread by the lodestar tick, which by the way is kind of ironic to me because it results in an allergy to red meat, lodestar tick, Texas cattle, that kind of connection. So tick saliva has this sugar molecule that galactose 1,3 alpha galactose, and the bite then triggers an immune response to this sugar molecule, which also is present in red meat and dairy. And this will cause an anaphylactic reaction to red meat dairy consumption. However, it won't usually happen until sometime after the tick bite. And even if you have the condition, it takes 3 to 6 hours after that consumption. Really, you can see that. It's been increasing in frequency. I think the estimate is there's about 500,000 cases in the United States right now. There is no treatment for it. The only thing that you can do is to avoid red meat and dairy scrupulously. And eventually, hopefully, that allergic response goes back. We may develop immunotherapy for it, but it is not there currently. Because this can cause such a severe allergic reaction, I recommend that anyone who is diagnosed with this have an EpiPen because it can compromise airways. So this is happening more and more, and it is present in Pennsylvania. Are seeing this. Next, please. Important point, how do we prevent this? Because prevention is always better than treatment, particularly in some cases where you have no treatment. So remember, ticks are active year-round, temperatures above freezing. If you are going to be out for any period of time, it is a good idea to use an insect repellent, something that is EPA approved for wear. You can also pre-treat your clothing with Comedic, which is easily available. We do recommend, even if it's hot, that if you're going to be in grassy or wooded areas, that you wear long sleeves, shirt and pants. And actually, I saw a tip recently, which I think is pretty good if you're going to be out for any period of time, to use duct tape and put it around your ankles with sticky side out. So that if you have them starting to creep up your legs, they're going to get caught. So I'm definitely sharing that suggestion. Do daily tick checks. If you're out and about at all, you really should do a tick check when you come home. And it also helps any clothes that you have that you're outside with. If you throw them in the dryer, very high heat for about 10 minutes or so, that will kill the ticks. Here's the real important point. How do you remove the tick? If you find it, you want to take it off right away. Do not use the match. Use the petroleum jelly. Grasp the tick as close to the skin as possible with fine-tuned tweezers. Do not grasp the body, as this will squeeze the contents through the bite into the skin. So grasp as close to the body as you can and gently pull straight out. Now, there's been also kind of anecdotally concern about the mouth parts. You can see the part that sticks out at the bottom. If they break off and get caught in the skin, which absolutely could happen. There's like a little cement that they use once they make that attachment. It doesn't matter. Those mouth parts are still there. Eventually, they're going to come out. And they don't have anything in them not to worry about. So the most important thing, use that tweezers, grasp as close to the skin as possible, pull straight out. Wash the area out. Next, please. Pennsylvania Department of Health has a very active program checking ticks for disease. So they will do surveillance in every county in the Commonwealth. And they use a lot of different methods. The simplest one is actually having felt fabric that they just drag through the woods, and ticks get attached to them. They do tick counts and they monitor for actual infection. And this is very, very active, going on every year. Next slide, please. So here's what we're seeing so far, and this is a little bit alarming to me. I remember many years ago, particularly when we had that Lyme vaccine available, a very large topic of conversation, that there were many, many years where the tick infections within, particularly ear tick infection, within Pennsylvania, very, very low. 3% were identified with the Lyme disease organism, Borrelia burgdorferi. Okay, so as you look now, if you look at all ticks, about half of them are carrying at least one of these. And deer ticks are right about the same. About half of them carry at least one organism. Most particularly with Lyme disease, it's somewhere between 30 and 50% have that. Anaplasmosis, which we are seeing more of, 8 to 10%. It's very, very common to see that along with Lyme, but these give a little bit less. Co-infections, at least 2 organisms, 30%. So the risk is definitely considered high. What that means is if you have a tick bite, there's somewhere between a 1 in 3 and 1 in 2 chance that that's an infected tick. That's very, very significant. So it's really, really important to engage in prevention, to try to avoid getting bit, to do tick checks, and to remove them as quickly as possible. Next slide, please. So here's a real interesting thing. East Stroudsburg University runs the tick lab, which will accept ticks mailed to them through a special mail order. And they will test it for diseases. If you are a resident of Pennsylvania, they will do the basic test for free. They have a whole panel of things they can do and do extensive testing if you want to pay for it. But if you are a resident of Pennsylvania, just want the basic testing, includes Lyme disease, you can contact them and they will do the testing for free. So I think that's a really great thing to do if you have any concern. It's a very easy URL to remember, ticklab.org. Next, please. Some other general resources, the CDC and the Pennsylvania Department of Health have really, really great resources. The Pennsylvania Department of Health has the tick dashboard where you can see everything that's currently going on in the state. CDC has some really, really good stuff in there. There's stuff for healthcare providers, there's stuff there for the public. And next slide, please. One thing in particular CDC has is this tick handout, which is easily printable. And I think it's really great for people to print this up, have it available. So if and when this happens, you can immediately refer to this. It gives you very good guidance on what to do and how to see further. And with that, that's why I will be happy to take your questions.
I guess just one quick point or question. Are ticks beneficial? Or are they like mosquitoes of great benefit?
So I'm not involved. It's their holiday. My limited knowledge, I haven't seen a use for them.
It really,
Yeah.
usually there's, everybody has, there's benefits for everything.
But. That's the question.
Yeah,
It's a little mosquito. Actually, if you get rid of mosquito. Yeah, this system fails. First the bats go, so the other.
So we're gonna move on, right? Yeah, so the Office of Public Health and Office of Drug Alcohol have been collaborating for quite some time, particularly around the action initiative. One of the strategies of that initiative is to support our clinical leadership and our health systems around integrating best practices into a setting to support drug disorder. Working with integrate. We thought it would be a great idea to have that conversation where like share what they're working on, all the games and technology, what you're noticing in your health system, and where we might be able to go from there. So sort of a kickoff conversation, and that they're open to.
Yep, so, if we could just understand which healthcare system is that becoming?
Mainline Health.
Jefferson and mainline health. And Temple, I guess, I'll be on all Temple.
Oh, okay. You know,
Oh, you saw.
Okay, so, Christina, like Christina said, so just to give a little background of our office, the Office of Drug and Alcohol, we are the single county authority for Montgomery County. There's one in every county in Pennsylvania, and we all answer to the Department of Drug and Alcohol program. We're responsible for treatment, intervention, prevention, recovery support services in schools and in communities, and the rehab, the outpatient programs for substance use disorder all fall under our purview in conjunction with Magellan, which is the for Montgomery County. So within the past 10-ish years, addiction and substance use disorder has become more of a medical crisis in addition to a behavioral health crisis, especially in the past 5 years with xylazine and methamphetamine. So we just wanted to introduce ourselves, start some relationship building. It's difficult for the behavioral health system to kind of understand and infiltrate the medical system. So building some relationships, kind of see if there's any substance use champions that you are aware of in your health systems that might be interested in collaborating with us. Some of the areas are in the emergency rooms, of course. Now also the ICUs, some individuals moving into that space because of the different adult trends. We would love to see what you're saying, what kind of support you might need, and just start to build from there.
Sounds good. Thank you.
And also specifically in the perinatal space as well. So, I mean, if you want to identify within your health systems and shoot us an email on potentially maybe build a work group moving forward, we're hiring a person who will span OPH and ODA here at the county who will be specific to healthcare relations and substance use disorder. And that person is supposed to maybe start to create a work group and just start to work in that space. And we're also have the emergency behavioral health center that's coming on board. So that'll be, I think, a collaboration point for medical and behavioral health services.
We definitely have people who we connect with.
Oh, great.
For Bryn Mawr and like,
I feel like like as all of the mental health, it's unfortunately kind of intersection. And in our follow, follow this. Yeah, where they have those episodic, extreme things. might be. All that balance. Cycle.
Yeah, I was just gonna kind of elaborate and say, we really believe within Montgomery County in certified recovery specialists and embedding them in emergency departments and really any clinical setting that we can really get ourselves into. We have been working over the last couple of years of really expanding the use of certified recovery specialists and engaging with healthcare systems to get a CRS in there, right? A CRS is somebody with their own lived experience. They've gone through this before. They can really connect with individuals if they're coming in post overdose, or really if they're just coming in for, like, say, a routine appointment and a doctor recognizes there's substance use going on. We love to have the opportunity for that peer to engage and hopefully motivate that person to connect to treatment and follow them through that process, because it is a cumbersome system. And it's hard for, medical professionals to know the ins and outs of how to connect somebody to our system. And so that CRS in our eyes is the person to help with that linkage and take the burden off the healthcare system. And so, like I said, we've been trying to build relationships with our local EDs to kind of offer the support of ACRS. Some healthcare systems are very, on board with this and are saying, yes, we'll accept whoever we can. Others are harder to get into, but if there are ever spaces or opportunities for us to expand that to any healthcare system you're affiliated with, please let us know. We have various funding sources where we can try and provide resources to that emergency department, or we can kind of leverage existing resources that we have to expand. So, for example, we have a CRS that has really been working with Pottstown Hospital, Tower Health, and we recognize that that person maybe has a little bit more opportunity, time in their schedule, the capacity to work with the Gilbertsville Emergency Department. So we're extending that person to kind of target two different EDs simultaneously. So again, any opportunities that we can have to kind of help the healthcare system with that process, we're happy to do that. And we really value the use of CRS.
Does the patient have to leave that for the CRS to come in, or get the CRS out? So I feel like sometimes the patient say, I'm good, thank you for all, I don't need it.
Correct, yeah. So primarily all drug and alcohol services are voluntary. I think a CRS is more than happy to show their face if they're in the emergency department to just kind of be like, hi, this is who I am, let me give you some resources. If you're not interested right now, I get that. Obviously they cannot force themselves upon anybody, but they can really, utilize their skills, their motivational interviewing skills to try and move the needle a little bit on the stages of change. Doesn't always work, but we have our fingers crossed. Hope that'll at least help somebody.
Are they available in the evenings and nights?
It depends on the provider. So some of our providers have CRSs that have like staggered shifts. So we, ideally it's available 24/7. Right? We know that this is a very pivotal time for somebody where if we can engage them while they're there in a controlled environment, that's where we're going to have the best opportunities for success. Unfortunately, with like funding restrictions and availability of staffing, that's not necessarily where we're at right now. There are resources such as like Global Crisis that operates 24/7. They have peers on staff. I don't think they have CRSs on staff 24/7 necessarily, but they have crisis workers 24/7 that can kind of help with that as well. So that is something we're trying to beef up and find the resources to make it available as often as possible.
And that's exactly the kind of question that we would welcome. I think you're like, well, we really need somebody at 3 a.m.
Yep.
We can think that through, talk that through. Sometimes you may feel like the barriers maybe like an accountable, but I'm sure we've heard them before, and we can build programs around what you guys identify as.
If they're not in the ED at the time, is there a possibility that the patient can connect to them at some point immediately following? Like your ED stay could be a little bit lengthy. But again, if that doesn't have the right hours, would they connect them later?
Yeah. We would work with any like system and with our providers to figure out a referral workflow. So if the hours don't align, send the information after the fact, and that CRS will reach out as soon as they're able to and start building that relationship. So yeah.
I think we'd be very open to it. I'm trying to think I don't think there'd be any objection on our part.
Like Barbara said, we get the consults with our patients, of course, on anyone that's spoken for any of the substances. They don't see them at night, which is fine, they're admitted, they see them in the morning. So for them to get information, you could say, learn about this guy, but invariably what I see honestly is, the note says, spoke to the patient, gave you person, not interested.
Yeah.
Because obviously, the person is not really wanting to do that. That's where maybe having someone who knows that pathway helps them and the resources.
And then for maternity patients, we do address this with our patients both in the office, but then also when they come into labor and delivery, we talk to them about use of different drugs, and we do test them. If they say that they've had any use, we test all of the patients that say that. And we've had really good success getting the patient, like understanding where the patient is, and sometimes child needs has to get involved, but I would think most times not. But we are being equitable about how we test. Is that it? Yeah. Oh, I think yeah, no, that's great. I mean, I've made notes. I will definitely, I'll send Christina my people to connect with.
Yeah.
And I'm somebody who's responsible for all of behavioral health for the system. But she can definitely speak to Bryn Mawr and Lincoln for sure. But I can't imagine we wouldn't welcome somebody to be part of this.
And also connecting with social workers when it's time for discharge.
Yeah.
Having to get to rehab. In the maternal space, maybe helping connect to medication to treatment if that's warranted. And we can even support in the child welfare case if that comes. That's something which.
Sure.
Sometimes maybe, depending upon county, but we contract with providers like Maternity Care Coalition and other programs that cross county. So
Yeah. Okay. That sounds great. We'll definitely make the connection for you.
thanks so much. And we don't have our contact information, but we'll make it there.
Yeah,
Thank you.
that's really fun. Okay, thank you. Nice to meet you.
Thanks. Thanks for everything.
Do we have any? Do we have anybody online that has any comments?
No.
They all have. So, well, thank you everyone for coming. It's really nice to see you in person. Our next meeting is September 9th. That seems like a long time away, but it'll be here before we know it. So September 9th is a virtual meeting. So again, we sort of alternate, and you need anything in the interim, just reach out. But otherwise, thank you. I hope you all have a safe, happy, healthy summer. And we'll hope for no events, although we are well prepared. We don't want to actually have to use any of those skills. Motion to adjourn. Thank you. Thank you. All right, have it done. But are you?
Good presentation.
Yeah, that was.
Thinking about what's new and everything else. And I've been pulling up things. Yeah. And you can hear everything. That's what I. You know, whether it's